So the Health Services Committee meeting. Have a very good agenda today. Before we start in the roll call, please allow me to recognize our newest member of our committee, Senator Chambers Armstrong, and certainly glad to have you as part of our team here. So if you would, please, everybody welcome Senator. Any other guests that we need to recognize this morning? If not, we'll jump right into the agenda. Secretary, if you would, call the roll.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll, Senator Funky Fromeyer, Senator Nemes, Senator Tishner, Senator Wise, Vice Chair Douglas,
Present.
Chairman Meredith.
Present. We do have a quorum and we will proceed. First bill on our agenda this morning is House Bill 75, and Representative Brandon Reed is here along with some guests. If you would, Representative, you as well as anyone knows the routine. We are reviewing House Bill 75 this morning, and I think it's a matter of coincidence, maybe not, that back in 22, Representative Reed also did House Bill 183, which is quite similar in scope to this bill. But if you would, Representative, please identify yourself for the record and proceed.
Thank you, Mr. Chairman. Thank you, honorable members of the Health Committee on the Senate. Truly appreciate the opportunity to come before you today. I am Representative Brandon Reed. I represent the 24th House District. That's Green, Hart, and LaRue counties. I do have a distinguished guest with me today. I will allow her at this time to introduce herself for the record.
Good morning, Nancy Galvani, President of Kentucky Hospital Association.
Mr. Chairman, members of the committee, HB 75 is aimed at improving access to the quality health care for each and every Kentuckian, as well as serving as a lifeline to rural hospitals serving communities throughout our Commonwealth. With HB 75 now granting access to hospitals to be reimbursed for outpatient services, hospitals will be able to harness federal resources while using no state funds. This measure simply builds on legislation, like the chairman referred to earlier, we approved back in 2019 and 2021 with House Bill 183, and provides an additional opportunity to harness federal resources. There is a budget mechanism for pass-through money that will be coming over in House Bill 448 through the budget process, but at this time, my guest has a few words to say, if that's okay with you, Mr. Chairman.
Thank you so much. Again, Chairman Meredith, for allowing me just to make a couple brief comments about the need for this bill. It's very critical to support our hospitals, because our hospitals, as I've testified in front of your committee in the past, are really facing skyrocketing expenses, and the revenues just are not there to cover that. And I wanted just to let everyone know that today a new report is coming out by Kaufman Hall. And Kaufman Hall is a national management consulting firm. They do national reports on the state of hospital finances. And so we contacted them and asked them if they would do a report just for our state. And so that is what is being released today. And I just wanted to let everyone know that report is echoing what we have been saying all along. And basically, the report found that in 2022, Kentucky hospitals faced their most challenging year financially since the start of the pandemic. They found that inflation, record high operating costs, and lower patient volumes led to unprecedented financial losses. They found that 38% of the state's hospitals are at risk of closure. A couple of the other highlights: operating expenses for our hospitals increased $4.2 billion since 2019. Labor expenses increased approximately $3 billion. The hospital spent $1.2 billion more in contract labor in 2022 than they did in 2019 prior to the pandemic. The growth rate in contract labor, medical expense, and drug expenses were higher in Kentucky than the national average. And in fact, the medical and the drug cost growth grew at more than 2 times the national rate. And so, as everyone knows, 3/4 of our patients in hospitals are on fixed payment from Medicare and Medicaid. We can't pass those costs along. And so the result is that Kentucky hospitals ended 2022 with a negative operating margin, equaling a loss of more than $250 million. And what's really important is that those losses occurred despite having the inpatient HRIP program. And so had we not had the inpatient HRIP program, in 2022, the losses would have been much greater. In fact, according to this study, they would have exceeded $1.3 billion. So this bill is very critical. We want to thank the members of the General Assembly for your support of this measure, and just can't echo enough that the timing is very critical for this, and we really need it to sustain our hospitals. Thank you.
Thank you, Mr. Chairman. I'd like to thank the Kentucky Hospital Association, the many co-sponsors, and the bipartisan work on this bill. That concludes our presentation.
Representative Reed, I always appreciate your commitment to this as well. Know your district well. I appreciate your commitment to it. Nancy, you threw out a statistic of 38%. Could you give me that number again?
Yes, this study found that 38% of our Kentucky hospitals are at risk of closure. And that's an increase. That's an increase.
Can you kind of stratify that a little bit between urban and rural?
They
Do
did
you have
not
that?
do that. They did not pull that apart. But I will say the sample of hospitals they looked at had both urban and rural in there. So they said it was a very statistically valid analysis.
Well, I remember even before COVID, I think the average profit margin for particular rural hospitals is less than 0.5 of 1%. And if it hadn't been for HB 183, I'm sure that number would have been even greater. But I think from a lot of the facilities that was going to be the saving grace for them.
Yes.
And I heard from a lot of hospitals that they were thrilled to have that additional reimbursement. But I guess that exuberance is short-lived when you're faced with the kind of inflationary pressures we're dealing with right now.
Yes.
So even with the passage of this bill, which I think is critical for all healthcare providers, what do you see coming next?
What this report shows is that there's no relief in sight for these high costs that are out there. So again, that's why this bill is critical, and particularly for our rural hospitals, because the majority of the money that's going to come in under the outpatient side of HRIP is going to go to the rural hospitals, and they desperately need it.
All right, thank you. Motion on the bills or second? Second by Representative Senator Nemes. Secretary, please call the roll.
Senator Rocky Adams. Senator Chambers Armstrong. Senator Berg.
Aye.
Senator Carroll.
Aye.
Senator Douglas.
Aye.
Senator Funky Fromeyer. Senator Nemes.
Aye.
Senator Tishner. Senator Wise.
Aye.
Chairman Meredith.
Aye. Bill passes with unanimous consent. We'll proceed to the floor with favorable expression. And, you know, I would ask for consent on this one, but folks, I really would like to be able to speak about this on the Senate floor because I think we need to make people aware that how critical the situation is. And I envision that when we come back in 2024, we'll need to try to examine other measures that could address the situation. But appreciate you being here this morning, and
Thank you, Mr.
Great
Chairman. Thank you all. Appreciate it.
thank you. Next bill is House Bill 180, and that's the Representative Moser is present along with guests. For those of you who are not new to this committee, we heard this topic during the interim. Great presentations on a lot of different folks' part. It's a very interesting subject matter. And with that, Representative Moser, I'll defer to you. If you would identify yourself for the record, feel free to proceed.
Absolutely. Thank you, Mr. Chairman. And I am Representative Kim Mosier. I represent the 64th District, and I'll allow my guests to introduce themselves for the record.
Hi, I'm Leah Phillips, and I am from Oldham County, Kentucky.
I'm Dr. Michael Gieske. I'm with St. Elizabeth Healthcare in Northern Kentucky. I'm the Director of Lung Cancer Screening.
And then online, we have Dr. Jill Colasar from the University of Kentucky. I don't know if she's on.
Can you hear me and see me?
Yes, thank you.
Oh, thank you.
If you could just introduce yourself for the record.
Hi, I am Jill Colester. I'm a professor at the University of Kentucky, and I'm also the director of precision medicine initiatives at Markey Cancer Center.
Wonderful. All right, thank you. I appreciate the opportunity to be before you today, and thanks to the committee for hearing this bill. This House Bill 180 is about getting the right treatment to the right patient at the right time. It saves precious time, it saves healthcare costs, and it saves lives. So, the problem is that most of us have been touched by cancer. We all have loved ones, or we know someone who has had devastating side effects of their chemotherapy, perhaps a treatment that didn't work right away, and they've gone through cycle after cycle of trial and error. And what House Bill 180 does, it simply requires health benefit plans to cover biomarker testing, which is ordered by their physician and will provide the correct diagnosis. Well, a healthcare provider who has treated a patient and diagnosed their cancer, what this does is targets their biomarker, identifies the patient's biomarker, and will identify precision treatment for their cancer. There's currently limited and disparate access to this biomarker testing because of a lack of insurance coverage for everyone, but especially in the minority and poor and rural populations. The fiscal impact study returned saying that this is not expected to materially increase premiums or the cost of health care in the Commonwealth. Oftentimes we know that, as I said, patients are getting what has been thought of as historically appropriate treatment, but it isn't. And again, this just gets precision treatment to the patient. It improves outcomes. I think at this point, I will just hand it over to my guest. Maybe Dr. Kolesar, if you can tell us a little bit about the background of biomarker testing and exactly what it does. I think it's a great education for all of us.
Thank you very much. I have some brief remarks and a few slides. I'd like to start out by letting you know about the difference between somatic and inherited. Somatic is something that is only in the cancer, where inherited is going to be passed down from children, down to your children. Approximately 90% of cancers are caused by somatic mutations, and another 10% are caused by these inherited mutations. And it's very critically important that we are able to understand what these mutations are, because it helps us select the correct treatment for patients, as well as prevents adverse effects. I'd like to next show you how far we've come since we've known about biomarkers. For those of you who are not used to looking at these survival curves every day, 100 means 100% of the patients are still alive, and 40 means the time. And so looking at the left panel, in 2002, the median survival for patients diagnosed with non-small cell lung cancer was 8 months. And it didn't matter what treatment you used, they all turned out to be about the same. Now, jumping ahead 20 years to 2022 and looking at the panel on the right, we have made tremendous strides in improving outcomes for our patients with lung cancer. The survival now is 4 years, again, compared to 8 months just 20 years ago. And the major reason for this improvement is in lung cancer, there are at least 12 different gene targets or biomarkers with more than 25 possible drugs. And I'd like to emphasize that more than 75% of patients with non-small cell lung cancer are going to be eligible for one of these treatments based on their biomarker testing. Let's take a little dive into what we are seeing more commonly in Kentucky. What this slide is showing you is that the rate of testing is low. There are a variety of reasons for that, including the lack of insurance coverage. And patients who are unable to access this treatment have poorer survival. The other thing that we know is that if you are living in Appalachia or you have Medicare or Medicaid insurance, you are also less likely to receive this testing. One of the initiatives of the Markey Cancer Center was to develop a molecular tumor board that it was really an implementation strategy for precision oncology, which is available free of charge to all medical oncologists across the state of Kentucky. And the idea behind this molecular tumor board was really to improve knowledge and understanding and uptake of this testing. I'd like to share with you just one of our outcomes. And again, these are going to be survival curves. And the red curve are patients who had a molecular tumor board review compared to the blue curve where patients did not have a molecular tumor board review. And what I'm showing you here in panel A is patients in Kentucky over the last few years who had biomarker testing and received a molecular tumor board review survived 8 times longer than their matched counterparts. It did not matter if you were taken care of in the community or an academic setting. And it did not matter whether you were living in Appalachia or an urban area. As long as you received this care, you did have improved survival. Thank you very much. I'm happy to take questions.
Thank you so much. I think we'll hand it over to Leah for a moment.
Hello, thank you for having me today. Like I said before, I'm from Oldham County. I actually grew up in Jefferson County and lived in Kentucky my entire life. In December of 2019, at 43 years old, I was diagnosed with stage 4 non-small cell lung cancer as a never smoker. At first, my diagnosis, when I was first given that diagnosis, they told me they hoped I was here a year from then. At diagnosis, they wanted to treat me with chemotherapy and immunotherapy, which would have been the standard course of treatment for a typical lung cancer patient. A different oncologist recommended that we do biomarker testing. So my biomarker testing revealed that I have the EGFR exon 19 genetic marker, which qualified me for targeted therapy instead of traditional chemotherapy, which increased my life expectancy, by 5 years. So I have less side effects, less severe hard side effects. I exercise 6 days a week. I have 3 kids. I run them everywhere, and I live a pretty normal, healthy life for someone with stage 4 metastatic cancer. Without biomarker testing, obviously, we heard from Dr. Kolesser, my outcomes would have been much less. I feel this bill is extremely important, not just for people like me that are educated and have access to this testing, but all Kentuckians, no matter their age, their race, or their economic status, because it is life-changing and life-saving for many of us.
Thank you, Leah. And so you can see how important this bill is just to allow the testing to be covered. Dr. Gieske, would you like to add anything?
Sure, I could say a few brief comments based on my experience. I've been in family medicine for 36 years now, and I've seen a lot of patients with cancer and dealt with them and their families, and it's always been a very difficult conversation. That conversation has gotten a lot easier over the last 10 years or so. We've made tremendous progress with all types of cancer, and a lot of that progress has been based on biomarker testing, either through liquid biopsies, which are blood tests, or through tissue biopsies. My background and my experience is specifically more with lung cancer, since I'm the director of lung cancer screening, but as we know, lung cancer is a terrible problem in the state of Kentucky. It's a very deadly cancer. It moves quickly through the stages, and unfortunately, it's often not found until it's late in the course of the disease. We're going after it now through our lung cancer screening program. We're finding it early and making a big difference for the state of Kentucky and for our country. But even when we find cancer in the late stages, stage 3 and stage 4, the message is very different now than it was just 10 to 15 years ago. We have patients now that are living 5, 10, 15, 20 years with stage 3 and stage 4 lung cancer. When I was in practice just 10 to 15 years ago, when we saw a patient that had stage 3 or 4 lung cancer, we felt that it was unlikely that they would be alive a year later. 50% of the people that present with stage 4 lung cancer or with any type of lung cancer do not survive more than a year. With the advent of biomarker testing and targeted therapies through precision medicine and through immunotherapy, we are making a big difference. And the family of lung cancer survivors is growing in numbers. Their voices are getting louder and stronger. And I and many others stand with them and feel that this type of progress should be available for all and not just for some, and that's what this bill is about. Thank you.
Thank you, Dr. Gieske. And I'll just close with, this is a standard of care. It's just not being covered by insurance companies. This is really cutting-edge treatment that Kentucky needs to get on board with. We are #1 in the nation for lung cancer, and we have to change that. So that's what this does, and I would appreciate your support.
Thank you. Fascinating presentation. It was as good today as it was when we heard it this past summer. And Ms. Phillips, I want to congratulate you on your recovery and appreciate you sharing your personal experience with us. But Senator Punky Fromeyer, you have a question, comment?
And thank you. And Leah, thank God those 3 kiddos are blessed. Is this treatment also commensurate with the patient's commitment to their own recovery or their own? When I hear that you're working out 6 days a week, is patient compliance going to also be a factor in whether this biomarker testing is effective for one patient if they're non-compliant versus Leah's commitment to be very committed to your own health and improvement? And I don't know that that's a question for you, Leah. It might be more of a question for our oncologist.
Yeah, I could.
Go ahead.
I mean, I could certainly add to that. Yeah, patient compliance is very important. As we know, cancer has many etiologies and factors in both the diagnosis and the response to treatment. Anyone that exercises, eats well, and takes care of themselves is going to be much more likely to do better with their cancer treatment. If they quit smoking, for example, reduce drinking, reduce weight, all those types of things are going to improve your survivability. But the drugs that we have available now are really the mainstay. I mean, just incredible success that we're having now with precision medicine and targeted therapies.
And I would say too, the targeted therapy that I'm on typically has a effectiveness for 2 to 3 years. I've been on it a little bit over 3 years. It's not a matter of if my cancer will progress, it is when will it progress. I will have to have biomarker testing reperformed to see if I have any new genetic mutations that would qualify me for additional targeted therapies that could be either added to the one that I'm currently on or added with traditional chemo in order to prolong my life even longer. So for those of us that are stage 4, that you're never going to be truly cured, stable is what we hope for, or no evidence of disease, then we need this biomarker testing to be able to receive the next best line of treatment as we go down our journey of this cancer diagnosis.
And I guess I would just add that this is really about covering the testing, not mandating any sort of treatment coverage.
Yes, please.
And this is me trying to learn a little better the legislative process as well, that if we were talking just before you about the affordability of costs and such. But sometimes I wonder whether we're spending dollars on a path that a person's not even committed to being on that path, but yet they've been placed on that path because their insurance might cover it, but they haven't necessarily been committed to that path of health or improvement or treatment. So my question comes back to what do we put in place to monitor the effectiveness based on compliance. Therefore, we can make adjustments for not making it available to those that aren't committed to compliance of improvement.
Yeah, and I think I understand your question. You know, when a patient is diagnosed with cancer, I think it's our obligation to offer the best treatment, and part of that is in doing this testing. We can't require that a patient comply with their treatment. Certainly, cancer patients are worn out by the end of some of their treatment. My mom was that way. After 3 years, she said, "I've had enough." So, you know, while we can only offer the treatment, we can't require compliance. And I don't think that we can separate out who will be compliant and who isn't and offer treatment only to people who would be compliant. I think that if a patient is diagnosed with this serious disease and they are going through the steps of getting biomarker testing, they're likely going to be very worried about their situation, and they are going to do everything they can to be compliant. So, you know, I I know that there are reasons why we think that patients aren't being compliant. Maybe they're, having a hard time quitting smoking. In Leah's case, she was a never smoker. Individuals are individuals. So I think our job is to just ensure that folks have the option for this treatment.
And being on targeted therapies do give you less harsh side effects. So I physically feel good. Whereas I've met other patients who are on traditional chemo and they are so sick they couldn't work out if they wanted to. Whereas since I've been given this gift of feeling semi-normal, then I can take advantage of that to help myself as best I can. Whereas someone who's on traditional therapies may not have that luxury because they physically, their bodies just can't do it.
I think that's an excellent point. I mean,